Okay, so we've got a session this afternoon on reimagining home care. We have some home care providers and representatives, Paul from Anthropos and Helen from TSA. We're going to be sort of talking about what the future could look like for home care and, importantly, how everybody in the audience can help us deliver that, some of the barriers that we're facing. And everybody in this conference has highlighted the remarkable demographic shifts that are happening. This picture is my great-grandma, aged 85, holding me, aged 1. And when my great-grandma was born in 1879, there were only 60,000 people over 85. By the time I get there, there's going to be somewhere between 3.5 and 4 million of us. And right now we can't cope. So what is it going to be like then? And we know that we haven't got enough workforce, we just can't manage. And part of our problem is that the investment is going in the wrong place. So the UK spends about 11% of gross domestic product on health and care, but almost all of it is poured into acute hospitals. And what we need to do is shift the dial on demand and put more of the investment into supporting people in their communities to live well at home and engage and build on their strengths. Home care traditionally has been a very people-intensive activity, using quite a lot of equipment which is fairly clunky and fairly old-fashioned. And there's always going to be a strong in-person element to care, but there's also now an absolute explosion of technology options and equipment options, actually using more modern AI and robotics that can help us. And there are different uses of technologies. We tend to muddle them all up, but I tend to think of them in 3 categories: technologies to support citizens, technologies to support carers, both professional and informal, and technologies to support care operations. And we kind of need to look at how we can make the whole lot work together. There's absolutely no shortage of devices and sensors and equipment. We've got smart homes that we've heard about. We've got wearables that will detect falls. There are remote consultations. There's communication via television, via computer, via smartphone, robots even. Many different options now, but we're kind of struggling to embed it, integrate it, and so on. And the prize is not the technology. The technology is an enabler. The prize is the data and what that will enable us to do, particularly in personalizing, deep personalizing of people's needs and improving outcomes. And we talk a lot about improving outcomes in the system, but we're measuring in home care, it's purchased by the minute. So who is going to worry about outcomes if all you're measuring is time? So that's one of the barriers. Definitely digital options help to drive quality and safety and efficiency. And when I think back to the days when we used, in my previous role, delivered home care just using paper, and I think, like, what were we thinking? But people are still doing that. Well, we didn't have a choice because there weren't any solutions, but it feels really quite sort of remarkable that that we did that. But ultimately, to use the data to enable predictive and preventative strategies, create data to help us with research and policy making, maybe to save costs, but that shouldn't necessarily be the driver. I mean, even to sort of hold the costs with more people, that would be a good thing, and ultimately improve as many lives as we can. So I'd say that we're on quite a long journey in home care, and it sort of started, as I mentioned, on paper, and some providers are still using paper care records, very manual processes like invoicing. Then the next sort of development is taking on digital rosters, and I'd say the majority of home care providers use digital rosters now. And then about 60%, we estimate, according to NHS Transformation Directorate data, are now using digital care records. Unfortunately, for some of them, the rosters and the care records aren't properly integrated. You really need a two-way integration to make that work properly, but that's where we are. The next stage beyond that is digitalisation of the whole care business. So it's not just the care records, not just the roster, but all of the other things that you have to do as a care provider, recruitment, training, invoicing, dealing with inquiries, marketing, monitoring your quality and your compliance and your clinical governance. When all of those things can be connected together, that's when the efficiencies start coming. And it's very difficult to go and buy off-the-shelf products now that enable you to do that. They exist in the United States. We're seeing some suppliers offering solutions that are really making great strides in that direction, but it's not widely available, so that's a challenge. And then beyond that, once we've sort of digitalized our whole care operations, then we can integrate some of these care technology options, the devices and the sensors that Paul will talk about, and how we can feed those data into our systems, and then the data science be used to predict and prevent and personalize in a very sort of extreme way, much deeper than we're now doing. And that use of data, I think, is the stage that we're facing into now, although not that many providers are anywhere near to that. But when we see how ChatGPT can be used, people are already starting to use tools like that to build care plans. And you could imagine being able to do assessments in a much more personalized way. And instead of just visiting people in minutes when you're told to, you only go when there's a trigger, when there's a need for intervention. And it's all the people that before they even get care, the pre-care cohort, where I think we can probably make some of the most important strides. So that's all I'm going to say, and I'm going to hand over now to Christina, who's going to talk from the perspective of a provider about actually some of the practical issues of putting all of this into practice. So thank you, Christina.
Thank you, Jane. Can I just check everyone can hear me? Great, thank you. Very disorientating. So good afternoon, everybody. My name's Christina Handyside-Dick. In a former life, I was a world champion sailor and 2 times Olympian. And for the past 11 years, I've been the founder of Guardian Angel Carers, a home care company. We have 3 owned branches and 11 franchisees. We're predominantly working in the private market. I'm also a wife and mother of 3, aged 7, 5 and 3. And Alison kindly invited me here today to talk about my experience with technology in home care. And over the next 10 minutes, my objective is to empower you with some of the lessons learnt through my own personal tech journey, inspire you to work increasingly with home care providers, and finally to share 4 business critical opportunities to achieve this. I'm going to bypass my Martin Luther King moment of I have a dream, because I think Jane quite nicely painted a picture of what the future has in store for us. We're at a time where demand is outstripping supply of our care colleagues. Yet I believe the problem and the opportunity are linked. Presentations entitled "Technology Revolutionizes Home Care" get me excited. And then when they're discussing rostering systems and digital care plans, I'm left feeling a little disappointed. Over the past few years, I've been on a journey experimenting with how we can integrate tech-enabled care and traditional home care to A, add value to clients by improving outcomes, and B, future-proof our services to meet demand. Now, this is going to also sound like a dirty word in the care industry, but also we need to commercialise the opportunity. This journey's included a partnership with Chichester Careline to provide care at the touch of a button. That was some 8 years ago. A GPS watch with panic button, health monitoring and sensors. 6 years ago, my mum had her first fall, and she wasn't going to wear a personal alarm pendant. So we trialled a watch which was more subtle. It had a GPS tracker, SIM card and panic button. The answer to all my prayers, or so I thought. It lasted 2 weeks. Less about the product, but more about service user buy-in. The reality was that it was me that wanted Mum to wear it for my own peace of mind. 2.5 years ago, Mum had another fall, this time breaking her hip. I see all too regularly the challenges of delayed discharge, muscle degeneration, and increased infection. And this was not going to happen to my mum. We had her out of hospital in 4 days with a 2-week live-in care package, decreasing to twice daily care visits, including rehab, all supported by our own carers, and a weekly physio visit. She was as fit as a fiddle within a month. Well, almost. She has neuropathy, which is lack of feeling in her feet, and it was only going to be a matter of time until her next fall. And what if she couldn't call me next time? Since then, I've trialled 2 different sensor packages in her home. One where you program in the rules to trigger alerts, and one where it learns behavior. I'll provide a little feedback on the difference between the 2 later. But in terms of addressing our problem and many others, they were perfect. Discreet, no cameras or microphones, simple, no wearables to remember, informative with actionable insights and text alerts. I'm hoping my phone doesn't go off shortly. And most important of all, from a worried next of kin perspective, it gives me peace of mind. It's taken away the not knowing. It's also removed fractious conversations where I'm trying to mollycoddle my mum. And now I can just let her live her life. And if I want to check in, I can just look at the app and check that she's moving and she's up and about. So in addition to trialling sensors, we've also trialled health monitoring kits. I saw firsthand the benefit as I used it daily with my surrogate grandmother following her self-discharge from hospital after breaking her hip, but coming out with a nasty chest infection. The health monitoring equipment, I believed, helped to prevent a hospital readmission, as we picked up early the ineffectiveness of her first lot of antibiotics. I absolutely love the idea of health monitoring in the community, but at the monthly cost per kit, I was struggling to make the economics of it work with a remote workforce and, of course, a generation that loved the NHS. I've spoken with several tech providers over the last few years, and when I ask who are your clients, the response is so often, we're running a pilot with such and such council. I don't believe that there's a lack of desire to work directly with home care providers, and certainly from us, not a lack of desire to work with tech providers. Because as we develop a new, more integrated, preventative and proactive model of care, this is going to be essential. So here are what I consider the 4 business critical opportunities to help make it happen. So firstly, using the power of augmenting an established market. So what do I mean by that? We lose around 25% of our new client inquiries because it's the worried sons or daughters that are contacting us. And when it comes to mum or dad, they just aren't ready for care. Converting these clients, we can build our funnel so that when they are ready for care, they choose us. We can provide that human touch, risk assess, advise and monitor data to provide recommendations on next steps. And this may help us to reduce those critical incidents that reduce quality of life, puts pressure on our NHS, and of course our social care system. I've got one franchise business owner who's currently installing a sensor kit per week. Now, that doesn't sound like a lot, but that's just one provider of, I believe, several thousand that we have across the country. So that's established that we've got a growing market at one end in this early, proactive, preventative side. But also at the other end, there's an opportunity. Who here would like to stay in a care home when they get older? Who would prefer to stay in their own home? So I think a resounding show of hands. Sadly, there comes a point for some when overnight care is needed. And this isn't cheap when we're providing it for just one person. But what if instead of having a single night carer or living carer to look after one client. They could monitor movement, alerts and/or alarm calls to look after a cluster of clients. And I believe this may already be happening with some councils and would certainly be easier with volume so that service users can be grouped geographically more effectively. A couple of weeks ago, we contacted our sensor provider to ask how best to configure the rules for creating an alert if there's no movement detected between any of the sensors within a certain time frame. Now, this company is one of the originals. They've been founded for 10 years, and their response was, "That's an interesting question. We haven't been asked that before. But don't worry, we'll develop something and have it ready in the next couple of weeks." And they have. I think the private home care market's got a lot to learn from the experience of council and NHS-led initiatives, which actually I think are ahead of the private market at the moment. And if anyone's got time, I'd genuinely love to hear more from your experience. But I also believe there's an opportunity with forward-thinking private home care providers who are likely to have greater agility to drive change and provide feedback to develop a shared service. So I think we've established that there's a pretty sizable opportunity. So why isn't it happening at volume? Why are we only on the top of the iceberg when it comes to fulfilling the promise of AI in our industry? It's really about leaders understanding the capabilities of AI today and then looking at how to apply it to add value. And the value of AI doesn't come from the technology, it comes from the changing workflows and operational processes. If I were to develop a new model of care, the tech would allow me as a care professional to add value through relationships. And therefore, having the tools to enable this are critical. These could include using all the data to build a care equivalent to what the healthcare system has as the National Early Warning Signs score. Creating a dashboard to show service users the score with the ability for us as care providers to provide recommendations on our insights. And based upon this, as well as the personal goals and wishes of the individual receiving the care. I know some tech providers, home care clients, are doing screen grabs and then annotating them, and I'm sure this process could be improved so that we can more effectively add value in a professional but not labor-intensive way. You could also allow white labeling so that text and email alerts are received from guardian angel carers or the home care provider, since we're the ones that the clients have the relationship with to create an end-to-end service. It's touched on a little bit yesterday around the risk, and I think this is one sort of barrier to entry, and I know has certainly been a limitation I've had with discussing with some tech providers, but some sort of standardized terms and conditions between the tech provider and the traditional home care provider that covers risk, liability, or in some cases, disclaimers thereof. We have a client with sensors whom, in addition, we provide once-a-week care visits to assist with showering. And this week, the carers have reported that the client's more wobbly on her feet than usual. Looking at her movement data, it showed that she was going into the kitchen at 1 o'clock in the afternoon. With this information, we've suggested that a morning visit to ensure that she's eaten and drunk, as well as taken medication to reduce the risk of dehydration, falls, and potentially a hospital admission. So critical opportunity 4, integration. In an already overstretched workforce, we need your help to get us as quickly as possible through the change curve. Because to truly integrate tech-enabled care and traditional home care, the software has to integrate too. Yet another operating system, will become a barrier to efficient workflows and operational processes, which is where the value lies. I thought I'd share a graphic, and Jane kind of briefly touched on this, but these are all the technology software systems that we use. Green is what I call your essentials, yellow is very useful, and orange is nice to have. At each arrow, there's some form of human data entry, or if you're lucky, an integration. But this seems to be the last step of the puzzle, as you want to be sure that the software delivers as hoped before the timely or indeed costly steps to integrating. In most part, though, it's not even in our control, as we're reliant on the two software companies having the capacity and indeed inclination to support with this. If you're a tech provider, particularly operating in the sensors market, could be a strong strategic move to partner or indeed merge with a care management system, which could shortcut you to the green zone. Or indeed, if you're like Birdie Care, then you might develop your own care management system first. So thank you very much. If you're interested in knowing more or just want to have a chat, I'll be around throughout the afternoon. Thank you.
Many thanks, Christina. Can you still hear me? Good. Great. Now, Karen, who's one of my colleagues from Scottish Care, going to talk about the work that they're doing in Scotland to support this agenda. So thank you, Karen.
Thank you. Thanks, Jane. And Christina also. I'm going to take these off. Hopefully you can... why am I asking if you can still hear me when I take those off? I don't know. Great to be down in Birmingham today to talk a little bit about the challenges that we're facing in Scotland and the opportunities ahead of us as well. It really is disorientated speaking, actually, in this room with this off. Okay. So, about 2% of people in Scotland are accessing home care. This is an infographic which is part of our campaign for social care in Scotland. Anybody else is welcome to interact with any of the materials, although we produced it. We don't own the campaign, so many different organisations have got on board. There's a range of infographics that try to demystify some of the myths that exist around about social care, particularly in the independent sector, which comprises the private, charitable and employee-owned organisations. So what does social care look like in Scotland? It's a complex landscape, really. I'm not going into each and every one of these, you'll be pleased to hear, but really it's just there to show you all the different components that are going on that sit and interface around about social care in Scotland. And one of the things that we fail at is we wait on leaders in other parts of the system to take us to places. A good example of this was the creation of what was called the National Digital Platform. So back 4 years ago, a colleague and I, Dr. Tara French, wrote a paper on seeing the diamond in social care data, during which we co-produced principles for data, how it should be shared. That work was done with providers, with local authorities, with people accessing care and support. They were very much co-produced. And the government said, that's okay, but we're going to design the system. We'll still build it ourselves. And lo and behold, we're still waiting on that system. So this is one of the failings that we do, is we wait on others instead of taking that initiative ourselves. And one of the things that's really exciting about coming to an event like today is the opportunity that we have with all the people that are in this room to have those conversations and start to move some of this work forward ourselves. Actually, I'm just going to go back a sec and sit there. But partnership isn't easy. Just before I came on, actually, I'm throwing this bit into my slides because it came up serendipitously in a conversation. I wanted to talk about partnership and relationships, because this is what we need to do to move forward. Collaboration is very much the vision for the future of working together, particularly when we're looking at our economics and achieving net zero, and actually in amassing the potential that we have as individual organisations with our own expertise and our own resources and how we share those, so that we can get rid of that campaign. I'm on a campaign against person-centred care. It's person-led care and support. This is what I was learning when I studied social work, my degree and postgraduate, which was well over 20 years ago now, and yet still today I've seen several presentations with person-centred care popping up. That's the dark ages, guys. It's person-led care and support. And all of us, we need to be coming here together and working together so that people can come to us and say, yeah, I want this, I want that, I want this, and it needs to work for me and to work for me now, instead of us all working around them, closeting them on that way, on that journey. So I wanted to speak a bit about what we've been doing in Aberdeen and in Fife. We have been creating collaborative working models. In Aberdeen, it's been a consortium, and that's just across providers of care, particularly home care. And in Fife, we've been doing that with the local authority as well, and that's really, really interesting, because what that has done is it's set rates of pay regardless of which organisation that you work for. So what it's done is it's stemmed that shift of staff from one organisation to another organisation to another. And what has enabled providers and the local authority to do, because the local authority has agreed to pay higher rates of pay, so providers can then pass that rate of pay on to their staff. And it's really reduced the attrition rate significantly. Sharing resources, sharing training. And part of that, they've created a route planning map, so they're now sharing route plans to deliver care and support far better and far more efficiently than they would do otherwise, because it's not about what company was highest up the list on the framework or the tender exercise, but actually about who is best placed and in that position to deliver that service at that point in time, because of the match of skill set, needs, and geographical location. In Aberdeen, we've taken that a stage further, and we're doing this around about technology as well, and introducing the care technologist role. So several years ago, a colleague and I worked with the European School of Innovation and Design at the Glasgow School of Art on a creative future for care at home. And out of that came 3 new job roles for care at home. And we've been trialling the care technologist role now for 3 years. Obviously, the pandemic came and slowed everything down for us, but actually speeded it up for us in other areas and other spaces. And this care technologist role is now part of the Improving Adult Care Together work, which is funded by the Health Foundation and the SRC. We're doing that with Birmingham University and others in that collaboration, to test how we can improve that implementation gap. Because there are so many good ideas out there, but we never ever get to put them into practice effectively and at scale, which is that pilotitis that you were both speaking about earlier. So the role of the care technologist is someone who is skilled and able to sit with people and individuals and talk to them about what technology would support them in their lives to do and achieve what they want to do. Person-led care, not person-centered care. And it's not rocket scientists, it's not rocket science. These things are not difficult. This is what the social care system should be providing already, but isn't and wasn't. So that care technologist role is making a huge difference to people's lives. It's now connected and linked with the Technology-Enabled Care Hub within the local authority, and they have a drop-in space, the hub. Anyone can go in, visit, interact with the technology. It doesn't matter if you're a part of the system, or if you're an individual looking to access care and support, or a member of the public who wants to know what there is available out there. It's mostly based upon products that you can purchase off the shelf on the market to make it as accessible as possible, but all sorts of other technology can be involved and engaged in that space. I said, and it's widened out to technology-enabled care. That means that resource is there for all care staff to go in and interact with as well. So we're sort of spreading and sharing that knowledge across the board. And it's just making it far more accessible and a far more normalized part of care and support. The next bit we want to get underway is the care navigator aspect of that role, of one of those roles, and that's the conversation about data. So same colleague, I did this, we wrote the paper, Seeing the Diamond in Social Care Data. How do we navigate our way through these systems? There's so many different systems out there and organizations collecting and collating our data. And of course, as James Clear says, we don't rise to the level of our goals, we fall to the level of our systems. So we need to be getting those systems to work together. And for an individual who's accessing care and support, actually that's just a human being on the ground that can interact and connect on that, because we don't have the AI or the National Digital Platform or those things running at pace yet to get us there. It's coming, and I can't wait for when it does, but until then, having an individual on the ground to do that connection, that human touch aspect of that, will certainly move things forward in that direction and get us into that AI space too. Sorry, I just added that bit in while I was chatting before I came on, so I'm just going to quickly roll on. time-wise. So that's the co-produced status principles for data, but you can see them in the report should you wish to. The slides will be shared. What I want to talk about is what happens next. What do we do when we go away from here today? And that work, those 3 roles, came from inspiration from this organization, Citra. They're based in Finland, and what they do is look at the art of the possible based upon the art of the probable. So they have just last month published their megatrends that they see coming in the future. Now, none of these should be a surprise to any of us in this room. But this is what's coming. This is what's coming our way. So we need to start posing questions about our present and about our future, but framed with these themes in mind. And that's going to be really hard. Because what happens is we get oh, well, we can't do that because, well, it's always been this way, or, well, I need the NHS to do, or I need the local authority, or I need my provider to understand. We don't have a work face. There's no money in the system. Jeff Mulligan has written a book this year that says that young people today see themselves as having a future which is more limited than that of their parents. Coming out of the pandemic, we are tired, we are exhausted. When you look at other natural disasters like an earthquake, things like that, there is time to recover before we move on. The sector needs that time to recover. You know, if there's been an earthquake, you have to clear away the rubble from the buildings, and you have to heal and then you rebuild. So we need to give that space, hence the need for holistic well-being to be there and to be part of that future that we have, underpinning and pushing forward our way for the future. So, I'm down to my last 40 seconds, guys. I wanted to finish with the futures triangle because this is how you can put this into your real life, start asking these questions. Think of a future-related topic, so care at home, what will that look like in the future? And if you frame it within these themes, so the push of the present, what is it that's driving us forward? Well, we saw the stats and the figures that my colleague spoke about earlier. That's our push, that's our desire. It's also person-led care and support. That's what we need to get there, and that's the pull of the future, is that real person-led care and support where we're working together to collaborate, to maximize our resource and to maximize our potential, and frankly just get this done. Stop waiting on national digital platforms and things like that. But what we have is the weight of the past, and that's going to hold us back. And those are the tough, knotty challenges that we need to find solutions for to push us on together. So I'm just going to finish with this quote. Never doubt that a small group of thoughtful, committed people can change the world. Indeed, it is the only thing that ever has. We all have the potential with us here today to work together and push some of this stuff forward. We're going to be doing some work on the megatrends later this year, launching in September. Get in touch if you'd want to get involved. Thank you very much.
Thank you, Karen. Thank you very much. Paul.
Thank you. So every time I hear Christina and Karen speak, I always end up thinking, I wish I was working with both of those organizations. So I'll join the queue of all of you at the end who wants to kind of catch up with both of them. The TSA asked me or invited me to come and speak in this panel and to talk to you about connected care and how connected care platforms work. But they set me the challenge of saying, can you do it without talking about the technology, and can you do it in less than 4.5 minutes? So here I go with an attempt to do that, and there will be a little bit of tech, but not too much within that. So what are we trying to do? The same thing as you are trying to do for the same 3 audiences. We are trying to use our technology to support older people to stay safe, well, and independent in a place of their choosing for as long as possible. We are also trying to use our technology to support their families, to give them reassurance and to give them peace of mind. But we are also trying to support the care providers like Christina and like the organizations that Karen works with to deliver a better care experience for those older people, better care outcomes for them, and if we can, support better use of time and resources by organizations like Guardian Angels. So how does it work? The only technology slide that's going to be here. Essentially how connected care platforms work is all the same. We put devices and sensors into the homes of older people. Those devices collect data. That data gets sent to a platform in the cloud where the data gets processed and analyzed, and we use it to develop a rich picture about the lives of those older people, based upon the environment in which they live, their daily routines, their patterns of behavior, their safety and security, and their physiological well-being. Having built that rich picture, we then use machine learning in the background to look for changes. And we grade the changes in two ways: changes that say that person needs help right away, and changes that say something is changing over time. Effectively, what we're trying to do is to deliver a picture of what happens in that person's life in the other 23 hours of the day when there's nobody with them, when there's no carer, no family member. And if you knew more about the way in which those people behaved, would you change the care you deliver to them? And that's what we're trying to do. And then, having created that intelligence, we send it to wherever you want it to go. It goes to care management software, it goes to alarm receiving centers, it goes wherever you want to point it. So that's what we're trying to do. And effectively, we're trying to answer three questions about that older person. We're trying to answer the question, are they okay? Has something changed in their life that means they need immediate help, so we can send an alert that says, go and help them right now? Or is something changing longer term in their life that suggests that a care professional should look at that change and decide if there should be an intervention? That's what we're trying to do. And those kinds of things, the insights that we're looking for here are changes in sleeping pattern, changes in movement, changes in hydration, nutrition, changes in bathroom usage, the kinds of things that should be useful within a care plan. Because ultimately what we're trying to do is to help you move into the new world that's been described by Christine and Karen, a world where you will be able to blend together physical care, the reactive care that you know from the telecare world, with proactive and preventative technology, and a proactive and preventative service. Ultimately, we will want to move into a world of being able to use the data in a predictive manner. We cannot do that yet. Anybody in here who tells you that they have the ability to predict anything happening to an older person or someone with learning difficulties is stretching the truth. Because in order to be able to do that, you need billions and billions of data points over a long period of time for a large number of people so that you can start to see trends analysis over the time. But what we can do right now is give you intelligence that supports making better informed care decisions. And ultimately, that is what all of these platforms are. And that's what they should do. So if you are wandering around the halls here and you're speaking to all the care providers and the people who deliver services, the people who create the platforms, the people who make the devices, ask them this question: how are you going to help me make a better informed care decision? There we go, 4 minutes. Thank you.
Thanks. And last but not least, Helen.
Okay, good afternoon everybody. My name's Helen Rodkin. I've got some slides coming up. Yep. So I'm just going to talk to you very quickly, because we're quite limited on time, just about driving quality, safety and continuous improvement and innovation in a care environment. So I head up quality improvement for Tech Quality. And Tech Quality is a subsidiary of the TSA. So it has its own board of directors, it has its own governance, and we sit separately to the TSA, slightly to the side, because we have to have that impartiality around our scheme. So our scheme is really about ensuring quality, ensuring safety into service delivery, and we do that by a series of different service delivery modules. So from our tech side, we have our tech assessment and installation, our tech monitoring, and our tech response service. But we also audit on community equipment, supplier and telehealth, which will be refreshed this year to be telehealth and virtual ward. So it's really important that it is an outcome-based scheme. So it is all about the service user at the end of all those services that are delivered to them, whether that's supplying or whether that's a service delivery, that the service user is at the forefront of that provider's service. So we ensure that there's robust processes in place. The scheme goes through an annual review. And that makes sure that we're looking at all the industry challenges that are coming forwards, that we're talking to our health, our social care, and our housing providers, and making sure that any of those policies that are coming down the line are incorporated into the quality standards framework. So you'll often see that it's the QSF, that does stand for Quality Standards Framework, and predominantly tech quality is about the auditing scheme. But we also work on lots of different projects. We've been working quite recently over the last year to 18 months with NHS England in improvement, doing lots of work around tech responder services and providing that universal response service. We're the only UCAS accredited scheme in the UK for technology enabled care. So you'll see as you've been walking around the exhibition today that there are lots of pink signs that say we are QSF certified and proud to be QSF certified. So those are the suppliers that have gone through the process, that have put that commitment into ensuring and embedding quality and safety into their service delivery. So the scheme itself goes through a really robust audit itself. So we get audited, the scheme gets audited every year as well. So we go through ISO 17065. There's a couple of our auditors in the audience today. We've got Wendy and Judith, can give us a wave. And they're 19011 certified as well. So we go through quite a rigorous process to make sure that we're really qualified to ensure that that audit process is robust. So really to look at commissioning to ensure the QSF standards are maintained. And you can see more and more and increasingly that in contracts and tender specifications that the QSF is cited in those documents, and also within tender procurement frameworks. We've got a few procurement frameworks here that the QSF is cited in there. We've recently been mandated in the recent NHS Health document that was sent out in October 2022 by Amanda Pritchard. And we've also, in terms of our TSA side, our TSA membership and consultancy are really, really good at helping with wording. So if you're putting together your new contract, your new specification, talk to your TSA. If your TSA members talk to that team, and they will help you get some really good and strong wording into your documents so that you've got this cited in there. Ultimately, when you've got the QSF, it aids contract management. So if you're procuring or you're commissioning a service that's got QSF embedded already, they've got that certification, then you know that they've gone through this robust process, because without it, you need to do that yourself. You need to make sure that you're managing those contracts yourself and making sure that they tick the right boxes. So in terms of technology and care, it's been great to hear from the team here today about it being person-led. It's technology-enabled care is that it enables the care at frontline service delivery. It's not about replacing face-to-face care if this is needed, but it is about making sure that the tech that's out there that's assessed and installed is regularly reviewed. People generally will deteriorate in health. You do get the other way where someone might come out of hospital if they've had a hip operation, for instance, and they might have tech as a short time solution for them. But ultimately, we see people going on that long care journey, that personalisation journey, where they will start to have different touch points along the way. So it's really, really important, particularly if they start to deteriorate quite quickly, that we continually reassess for tech and make sure that it's fit for purpose for that individual. Proactive and preventative care is massive now. It's really important, and we need to drive this forwards. And this year in April, the proactive and preventative criteria is added to our gap analysis document, which is the document that we use when we go out to audit. So for those organisations that are delivering proactive and preventative, they will be audited against those new criteria. It's different to the general reactive tech that can be delivered. And what's really important about the proactive and preventive is the way that, you know, the staff, the workforce, the different ways that they are trained. And again, we've got Samantha Davis here today, who's been looking at through the virtual house, beg pardon, the training on there. So if you haven't been to the middle kiosk there, you can see how a carer can look at those different technologies within a home environment and really pick up some really good skills. So speak to Samantha on there. So we know that services will evolve, it will move forward, and the QSF is often quite the glue to all of this. We sit within care, we sit within health, we sit within housing. People that go through that front door to that person come from all those elements of those places as people go on that care journey. So it's really, really important that tech is a big part of that, and that we continue to reassess people as we go forwards on that journey. So just a call to action for everybody, if you're either commissioning, procuring, delivering services, is really to make sure that your organisation is QSF certified. We want to achieve better outcomes for people. Ultimately, we want to make sure that people are safe within their homes when they want to stay in their homes for as long as they can. So thank you. That's a quick zoom through there, but if you want any further information or have got any questions, by all means get in touch with me. Thank you very much.
Thank you very much. Okay, I think we've got about 5 minutes for questions or comments, so I don't know if anybody in the audience wants to say anything. One of the things I was going to comment on, Christina, was your thing about human factors. So even though it made logical sense for a sensor or device to be in your mum's home, she didn't want it. Do you have any ideas for how we can address those kind of issues?
Great question. I think at the end of the day, it comes down to consent. So we know from a care background, you can't force someone to do something that they don't want to do. But as the worried sons and daughters, we also have some sense of responsibility for looking after our aging population and indeed parents. And so I think it's around sort of from a worried sons and daughter perspective, some sort of encouragement that isn't obtrusive and that's easy to understand and to use. And that's why I like the sensors. Mum doesn't have to think about it or worry about it. There's no kind of nails and permanent fixtures in her house, just some discrete sensors that are stuck strategically with double-sided tape in places. But yeah, it's a tricky one that we've got to kind of work and find our feet around.
Is there anybody? Oh, hi, sorry. So, there's a microphone here. Oh.
I like the examples of leadership coming from other than the NHS and local authorities. Have you got any examples of where that's worked, where leadership has come from the voluntary sector or the provider sector and local authorities have just got out of the way?
Happy to take this, yes. So the example of the collaborative or the consortium model in Aberdeen actually wasn't so much about, or indeed in Fife, wasn't so much about the local authority getting out of the way, but actually being part of it. So it was about an equality of power. And how do we get the lived experience voice in that co-design space as well? So as much as local authorities and the NHS can often be the blockers in this, actually they can be agents of change too. Now, we were fortunate, and I think this is one of the reasons that the leadership happened in Aberdeen in the first place, is because the chief executive was a former chief executive of a provider. So I think they brought with them that learning, that commercial experience, that understanding of that innovation happens on the ground, and then could create those conditions. They invested in time and space as well for people to come together and think, because culture is not an easy thing to change, as we all say. In fact, there was a great quote I saw on Twitter a few days ago, which was like culture eats strategy for breakfast and something for dinner and whatever it was. And I need to get a hold of it because it was brilliant. So that really, really helped, because it puts things on that even footing, and removing the power imbalances started to show, people could dip their toe in the water. Okay, so if we collaborate on this bit here, then we get good results. And now, because of what happened in Aberdeen, we could then share that in Fife, and they took a different legal model amongst the providers. It's much more fluid, it's much more agile. But again, that's something else that you dip your toe in the model, and then you can show somewhere else. And that's partly why the work that we're doing with improving adult care together is really important, because that's about the implementation gap, and how do we bridge that, and how do we use those different models to stop the pilotitis that we're currently suffering from. So watch the space, because they're now in year 2 of that work. It's a 5-year program, and it'll be really interesting to see what are those conditions that we need to create and sustain and embed change.
I think it's important to remember as well that there are a lot of people pay for their own care and don't even come into the local authority radar. And I'm sort of thinking about, Christina's example of her mum. Maybe if the GP had said, it'd be a really good idea for you to have a sensor, she might have listened, because that generation tends to take more notice of the medical professionals than they do of their sons and daughters, and how would social care even know about the local authorities wouldn't even know about some people, but pretty much everybody is on a GP record somewhere. So I think we just got to work together, because between us we will have access to everyone, but if we just do it in pockets, we're going to miss people.
Do you mind if I come in? So that's one of the reasons that the care technologist role has been popular, because where they start is, what do you already use? And then start to add pieces of kit from there. So you're meeting the person where they are. Somebody earlier said about designing around the system, not the person. I think that might have been this morning, actually, apologies. But it is that, how do you meet people at the point of where they are and take them on that journey, or let them take you on the journey with them? Because the second question is, what matters to you and how do we get you there? Rather than, there's all these great stuff out there, let's move it. But we're back to that, how do we make tech normal in everyday lives as well? How do we showcase this stuff on EastEnders or whatever else is, pick your poison. But, in the Archers, they've recently been doing this stuff in care homes, where there's been nothing on technology. And
we need a soap opera for home care. Yes, definitely. I think probably one last question, because we're running out of time. Yeah.
I'm interested in the care technologist role, and is that a formal qualification they will hold? I'm just thinking about clinical safety, and if decisions are being made by a health clinician or somebody who's sort of trained, are you going to have any sort of standards that they are trained to?
So the jobs at the moment, they have job descriptions, all that's available. You can download it from our website, you can take them. As for the training and skills, this is still in development, but we're working with NHS Education and other skills providers to try and create career pathways, because that's the other purpose for it, was to have career pathways for people who come into home care, and other opportunities for them once they're in that frontline role as well as attracting people from other parts of the system into social care. So it's definitely work that my colleague Nicola is leading on, so I can connect you if you like.
Great, thank you. I think we're out of time, but thank you very much indeed. Thank you to our speakers for really stimulating, interesting, informative presentations, and to our audience for being here and listening. Thank you.